All right. We are live with the man, the myth, the legend, Dr. Sean Rockett. Sean, thank you for joining us this evening for Grand Rounds. It is an honor and a pleasure, sir. How are you doing tonight?
I'm happy to be here, getting over a little cold, and so in case I'm taking my hot tea here, excuse but the show must go on. So
Well,
we're
if you need a consult afterwards, I'll only charge you three-fourths of the normal price.
just send me a Z pack, I'll be fine. Z pack cures everything, cures everything, even viruses.
Everybody, you get a Z pack. You get a Z pack.
You did.
Well, it's an honor to have you here, sir. Dr. Rockett truly is a legend in our space. His CrossFit journey dates back to the very beginning, where he's one of the founding members of CrossFit New England, and he attended Harvard for undergrad and went to Tufts for medical school and for residency. Subsequently, went into orthopedics and now owns one of the co-owners of Orthopedics New England, which has 3 sites and has been operating. Gosh, it's over 20 years now, right, Sean? 18.
Yeah, coming up on 20,
Coming up on 20.
25,
Yeah,
yeah.
that's amazing. Yeah. So he has
I'm
been
old.
working at the CrossFit Games, volunteering, I should say, and working to serve the community since 2011, and has been there for many of our pro athletes at the game. So it's a real honor to have Sean here. He's going to talk with us this evening about the shoulder. Anybody who's been doing CrossFit for more than 6 months, it's a topic that's near and dear to our hearts. So I'm really excited to learn from Sean this evening, and I know that this is going to have a lot of pearls, a lot of great content for everybody out there. So, Sean, without further ado, I'm going to hand it over to you. In general, moderate the chat if questions come up while we're going through.
I'm out there and we'll dig in.
Yeah, we'll go from there. So the floor is yours, sir.
Awesome, thank you. Thanks for having me. So the shoulder is a very popular topic for CrossFitters, as you said, because it's a very upper extremity intense situation where you're asking this ball and socket, as we see here, to stay in place and to do a lot of lifting and moving. If you look at it, this is going to be a very basic talk, but I'm happy to get as detailed as people want to get with. But so starting off with some anatomy for people that may not have ever seen what the rotator cuff is, you got the ball in the socket here, and then there are 4 rotator cuff muscles: the supraspinatus, the subscapularis. The supraspinatus is what helps elevate your arm, abduct. The subscap is what helps rotate internal rotation. And then this is a posterior shot, or a shot in the back. Infraspinatus and teres minor help rotate out. So those are the cuffs, but I can talk about cuffs, but I was sort of going into labral tears with this and focusing on labrums and things that I've seen with athletes, games athletes, and everyday mom and pop CrossFitters, and everyday sports, young sports people too. So if we took away that ball and socket and took away the ball and looked in at the socket, you see here's the rotator cuff, and the ball is moved away, and now we see inside the joint, and now we see this beautiful little suction cup device called the labrum, and that is really important for stability of the shoulder. The reason is because these ligaments all around here attach to the labrum, and if we go to our shoulder instability, so a lot of this is coming from my website and my book, 321gomd.com, and then the book is Where Does It Hurt? And you can find that on Rogue Fitness. Little plug right there. So if you go to shoulder instability, and this is on the, you'll see the shoulder is basically a big golf ball with a small golf tee, a big, huge, oversized ball with a small little golf tee here, the humerus and the glenoid. And you're asking, this ball to stay in place. And you can see it's certainly not going to stay in place just by this socket. It's too small to keep everything in place. So what keeps that ball in place, if you go down further, are the ligaments, and these ligaments attach the ball to the socket, as you see here with my uh, cursor. And there are these major ligaments: superior glenohumeral ligament, the middle glenohumeral ligament, and the inferior glenohumeral ligament. And one of the more important ones is the inferior glenohumeral ligament, and I'll show you why. Because when you get up overhead, which we tend to do in CrossFit, that inferior glenohumeral ligament is going to act as a big wall, and it's going to be a barrier to translation, to anterior translation. So anterior translation is here's my socket, here's my ball. Anterior is if it comes out forward. And that's the most common instability that we see is anterior instability. You can have posterior instability if it goes out the back, or you can even have inferior instability. So when you're talking about instability, you want to kind of define, number one, which way is the ball going? And that's instability, is when the ball translates out of the socket. The other issue is you want to find out, was there trauma? As a coach, as a physician, you want to, somebody says, oh, I dislocated my shoulder. And you want to find out what did you do? Did you land from a height, or were you just reaching up in front of you to pick up something? Reaching in front of you to pick up something is a whole different ball game. That's a more of just a loose ligamented type person, and we'll get into that when we talk about multi-directional shoulder instability. So yeah, Tom was asking, good question. I like this. You get a little question right off the bat. Most common instability traumatically is anterior by about 95 to 99%. So that's more of fall onto your shoulder or the snatch. When you get a snatch and you go up overhead, and you could dislocate your shoulder that way, or even from a kipping pull-up where your arm is up overhead. If the shoulder dislocates, 95% of these people who dislocate their shoulder are going to have that anterior instability. Very rare is for posterior instability, where it goes out the back. But that happens sometimes if you fall, if you're running and you land and you fall onto your arms, you can pop the shoulder out the back. Also with seizure, if somebody has a seizure in the box or in the gym, they can dislocate their shoulder out the back. So very rare for that. Inferior instability is more of a multi-directional situation, and we're going to talk about that, where the shoulder just kind of droops down because these ligaments here, that inferior glenohumeral ligament, is very droopy, and it doesn't provide the stability, which is what we need for the shoulder to stay in the socket. So that's instability. So instability is defined by the shoulder, the ball moving out of the socket. So awesome question there. If we look, and we talked about the snatch, and I think this picture is from Dave Ray, the photographer here. You look at Rich Froning he is externally rotated and he is overhead. So when we go back to that ligament, that inferior glenohumeral ligament, this is a picture in neutral rotation, which is my arm like that, neutral. This second picture is in IR. See that IR is internal rotation, so hand like that. And then this is what I was talking about, that inferior glenohumeral ligament in external rotation. That looks familiar? Everybody look familiar? Like beautiful mobility. So that ligament provides that structure, that wall, to prevent that ball from riding forward, especially when it's externally rotated and abducted in positions like a snatch or a pull-up. So just like this is an everyday position here. So what happens if you are going for you've got a 225-pound snatch, I know, Tom, right? Maybe 270, 275, 300. So if you overexert that snatch and it goes too far and you go back, you then can get this ligament over here to tear. And it typically, it can tear anywhere. It can tear over here, it can tear here, and if it tears here from the labrum, attaching to the glenoid, then that's called a Bankart tear, and that's a very classically descripted tear in the literature, in the orthopedic literature. This has really gone back to Hippocrates has described this dislocation of the shoulder, and then Bankart was the doctor in the 1900s really who looked at this lesion causing shoulder dislocations. They've gone through ways to figure out in the whole history of shoulder and medicine of how to get this to stabilize. And it was Hippocrates who actually talked about sticking a hot poker into the shoulder area in the front to prevent this from happening. Number one, what the hell did that do? That was like, you'll never come back and see that doctor again, right? Like, oh, I've got this treatment for you. I'm just going to stick a hot poker in your shoulder. The other is what it did actually was scarred all this tissue down, like all this muscle and tissue in there scarred down. Wasn't a great surgical repair, and certainly didn't cosmetically look great, and probably couldn't bill for that. But so what happens is when you lose that labrum and this ligament becomes loose up the front, right here, you see the labrum pulls away, and then when you go up overhead, that ball rides forward. So that ball rides out of the socket. If it rides too far, so this is called a subluxation. If it rides too far out, then you get into a dislocation, and that's what happens. And this is why sometimes you see this thing called a Hill-Sachs defect. Sometimes that becomes very difficult to reduce. You can't get that reduced, so you have to try to pull this away and pull it out, and it becomes sometimes very difficult to do that. Hopefully nobody's passing out with that. Everybody sit down while we're watching that. And so then here's anterior, here's posterior. We talked about that. So, what do? Do you live with this? If you're young, and this happens at a young age, we've studied recently a lot of more recent studies from 2000 to 2000 to 2025. The studies are showing that the recurrent rate of your first time dislocator and you're below age 30, the recurrence rate can be anywhere from 50 to 90%, that it will happen again at some point in your life. And so the issue is, do you just keep letting someone dislocate? The studies more recently in the past, say 5 to 10 years, have shown we're changing our attitudes when it comes to dislocation, that we don't want to continue to have somebody do this. Because if you do this, you're going to damage your shoulder, and it's going to get to the point where sometimes you can't repair it surgically or arthroscopically, and you need to add a bone graft here to prevent, if you start dislocating, you can wear away this bone. And then sometimes the surgery becomes a much, much bigger surgery where you actually have to add a piece of bone here to prevent this from coming out. So our aggressiveness with first-time dislocators, especially in young athletes, has gone, way up. So recently we've sort of been pushing, if somebody dislocates once, to reattach that labrum. Because why do we say that? We know that the surgery is a lot easier. The tissue has just been damaged once, and the reattachment is an easier surgery, and it works better. So if you have gone through a second dislocation, say you go to the doctor and the doctor says, I want to fix that, and let's figure out a time to fix it. And you go, thanks, doc. My dad told me back when he was, blah, blah, blah. I'm not going to do that. They come back for the second dislocation. The success of that surgery goes down dramatically. So two-time dislocators and even three-time dislocators, it keeps going down. The success of a surgery keeps going down the more you dislocate. So our thinking, and sometimes our thinking changes in medicine, and we like to have studies to prove it, and we do have these studies that have shown that the success rate goes down. So we're being much more aggressive with these first-time dislocators. If you're in the middle of a season, a sports season, we try to let you get through the season and then fix it at the end of the season. So we try not to take you out in the middle of the season for that. And so what does that entail? That is called a labral repair right here. So here is the ball, the socket, the labrum is detached. And what we do is arthroscopically with these three portals, three little cannulas that go in, we put a camera in the back. That's the camera in the back. We go in and we look and we see that this labrum here is pulled away. And then we have a working shuttle over here. And then we have a drill and an anchor. And the drill, number one, goes in, and there's these little drill guides. It's actually like little tiny, 2.9 millimeter, 1.9 millimeter drills. You hold a cannula, you drill through, and then you keep the cannula there, and then you tap in this anchor, and that anchor goes into that hole, and that's called a suture anchor, where this anchor lodges into the bone. The anchors are made of either plastic, or actually they're now coming out with suture material, these big wad of tissue where it goes in and then you pull it back and it deploys and you can't pull it out, and it's very strong. And so then you have this anchor anchored into bone, and you have sutures attached to the anchor, and then you pass the sutures around that labrum and that ligament. So what that is doing is that is tightening up that ligament that was detached, reattaching the labrum, and thereby tightening up that ligament to prevent any recurrence. Recovery from that sucker is, depends on what you're doing, but to get back to contact sports can be 5 to 6 months. For overhead CrossFit type athletes, can be 6 to 8 months to get back to doing the kind of gymnastics, mobility type of things that we like to see. That is the anterior labrum. Or do you have a question?
Yeah, I was wondering, Sean, if you could talk a little bit about the role that therapy and rehab plays after this process and what it's actually doing.
Sure.
'Cause I
Yeah.
know, recurrent, at least intuitively, it's always seemed to me, one of the issues with recurrent dislocations that you may be getting more laxity in
Mhm.
the ligamentous structures, which could make it more unstable, but it also could be that the labral tear is just progressing as well. What is therapy actually doing? Is it strengthening the musculature? It's not increasing
Right.
tightness in the joint with the tendons per se, right? It's
Right.
building up the musculature around it. So can you talk about that laxity and the role therapy plays and what it's actually doing?
Yeah. So looking at this picture, you see the labrum detached, and the yellow is the ligament, and then the white is the rotator cuff, and the rotator cuff muscle bellies here. So the goal in therapy is to try to build up the tendon and the muscle to try to keep this in place.
Mhm.
And sometimes it works and sometimes it doesn't. For an older person over age 30, first time dislocator, there's a good chance that they can not dislocate again. So I was talking about really, below age 30 when talking about really being aggressive and recommending surgery. For somebody who's over age 30, say somebody is 50, they fall, they come down off the bar and they trip and they fall, or they, dislocate even with a weight over their head, but they're age 50. That's a different story. That's a different category, and I'm glad you brought it up, because older people can have one dislocation and not have it again. So we're much more conservative with older people, and over age 30 is older.
God help us.
God help us, right? Um, but the issue, if somebody does dislocate and they're 50 to 60, you got to be careful to check the rotator cuff, because there's a high chance, around 20% chance that someone can tear their rotator cuff at age 50 or 60
Okay.
with a dislocation. The other part is fracture. That if somebody doesn't have great bone strength, their tendons can actually be stronger than their bone and pull off this piece of bone that is attached. So getting an X-ray is really important if you're over anytime you dislocate, because anytime you dislocate, you could either break that bone, that glenoid, that's called a Bankart fracture, as opposed to a Bankart tear, which is just the labrum. But then you could also check and pull off a piece of your bone of your humerus. But yeah, rotator cuff strengthening and mobilization. Initially, for a 50-year-old, you're going to just wait and see, let it calm down, let this labrum try to heal. And sometimes it heals well, and sometimes it heals, but it heals down here, or it doesn't heal in the normal position. And then that's a setup for instability also.
John, do you know offhand what the frequency or the percentage is for a partial rotator cuff tear for a young person under 30 who has a dislocation as opposed to an older person?
I would say it's almost unheard of.
Okay,
Yeah.
extremely rare.
Yeah, rotator cuffs below age 30 are real. Like I can remember a handful of rotator cuffs in my 25 years. It's, when I hear a kid come in and say, "Oh yeah, I tore my rotator cuff," I'm like, "Who told you that?" And they're like, "Oh, that's what," and so it is extremely, extremely rare for a rotator cuff tear.
Right.
You could get a tiny little, scuffing, but as far as a complete rotator cuff pulling off, it's really rare. Yeah. So then that is, that's the inferior labrum, which is, again, the most common if you're talking about dislocation and instability. But then if you look up here, we break up the shoulder into the superior, that's up above, superior labrum. This is the anterior inferior labrum, and that's the Bankart tear. And then you have the posterior labrum back here. Posterior labrum's pretty important in CrossFit, and I've seen it with people with burpees. They land, they jump down, and they land, and their shoulder gets pushed posteriorly.
Are you listening, Jim?
Is this?
That may be her favorite CrossFit move. So I'm glad,
we do a lot of burpees. I think
glad we now have a medical reason that we need to decrease burpee volume.
You heard it here, folks. You heard it here. I'll write you a note.
Don't let him get out of burpees that easy. Come on now.
And then sometimes bench press, like a sudden bench goes out the back. I've seen that. Someone said like that they're like up high and they just all of a sudden it's a heavy weight and they go and they say they feel something. So benching, very important. And then sometimes even just depending if you're into a clean and jerk, sometimes the force of the weight is pushing out the back. And then I've seen that with a labral tear, posterior labral tear, but I've also seen it, and this is probably a good segue into our multi-directional instability people, where you don't have a tear. And let me show you that. So you are loosey-goosey, like you are a swimmer, a gymnast, or a Cirque du Soleil performer. And if your ligaments can do this, if you can hyperextend at the elbow, if you can take your thumb and have it hit your forearm, if you can take your finger and have it pointing 90 degrees up, like, so you're just inherent loose person, and you don't have an injury, and you don't have an injury, but like when you go overhead, you don't like it because like it just hurts. And sometimes you'll get tingling and pins and needles in your fingers when you go overhead with a heavy weight. And what's happening is this ball is going down here, hitting the nerves, the brachial plexus coming out of the arm. So you can, somebody comes in and says, "Oh, I feel my shoulder sublux or shift." And I'll say, "Okay, what was the first injury? Did you dislocate?" And they go, "No, I've never dislocated." And, but sometimes I reach for something and I feel my shoulder shift. Or if I get a weight overhead, I'll feel it like move, but it never dislocates. And so that's that loose person, age 20 to 40-year-old female, who doesn't have a dislocation, but this ligament here is just loosey-goosey and it moves around. So you'll do an MRI on this person and they'll come back normal. You have a normal shoulder. There's no labral tear. There's no rotator cuff tear. I don't know what you're complaining about. No. But this is a classic example of somebody, and you know, again, I've been doing it a while, especially with CrossFit people, and I get a lot of these people. They come to me because they've seen somebody and somebody said, okay, we'll do the MR arthrogram. You should stop CrossFitting, by the way. Did I tell you that? You should stop CrossFitting. And we'll do the MR arthrogram. And okay, I told you, okay, maybe it's okay to CrossFit because you don't have a tear. But these people are like, well, I can't like reach my arm up over my head anymore. They're like, well, stop doing that. You know, so this is a classic example, normal labrum, normal, and what they have is just a really loose shoulder. And these people are the people who you really want to hit with physical therapy bats. Just keep strengthening, keep trying to build up these back muscles, keep trying to build up your rotator cuff, all these muscles. Oopsie, not that one. So these people, all these back muscles, and that's, you know, crossover symmetry is great for that if people have that, or even bands, any of the bands that you can find. Great for these muscles, the rhomboids, the trapezius. These are the rhomboids. These are your levator, scapulae, your trapezius, your deltoid. These are the things that you need to try to build up. But again, sometimes you get to the point where that capsule is too loose. And, you know, if you have somebody who's really loosey-goosey here, and what you can do is called a capsular plication. So it's not a labral tear, but again, these are people who fail therapy. You say, okay, you need probably a good 3 months of modifying, backing off overhead stuff, anything that causes symptoms. And I really want you to focus on building up those muscle groups. And then if that does not work, then it's called a capsular plication, where you take this capsule and you tighten it up. It's like you go to a tailor and you have your pants are too loose. You imbricate, or you tighten up the capsule, and what that does is that shoulder that's droopy all of a sudden now sits up in its proper position. And I do this not frequently, but for the people that I choose to do it on and the people that need it, they love it. They're like, oh my God, my shoulder just feels like it feels like it's in a better spot. It feels like it's supported. But again, this is not for everybody. You don't want to you really want to work rehab on this. And it's people that have had trouble for at least 6 months to 8 months to a year of symptoms. And so if you pick the right people to do that, they love it.
Sean, I assume that those folks with multidirectional instability are more prone to dislocations. Would that be true or no?
Well, it's kind of funny because they're so loose and floppy that they just kind of go all over. They never get all the way out because they're all
Sublux, they never fully dislocate.
right, right. They just sort of sublux and they move around and they shift around. Yeah.
Okay.
And people will tell you, people like, you just listen to people. People will say like, yeah, I feel my shoulder shift, or I felt my shoulder move. Like anytime somebody says that to me, like it's pretty accurate.
Yeah.
Like I've never heard of somebody like making that up, or you know, like anytime somebody says I felt my shoulder shift or move, or I felt like a rip or tear or a pop, like that's pretty accurate.
So you're saying we should actually listen to what people say?
Throw that in there, put a little sincerity while you're not doing your Sudoku puzzle, you know. I'm sorry, that's anesthesia. No.
It is. They don't have a paper in their hands, legs crossed, and a pen. They're not doing their job.
Yeah. And then, so going around the horn, so we talked about posterior labrum, we talked about anterior labrum, and then you get into slap tears. And this is a very common thing in the CrossFit world, sort of superior labral tears. And it's where the long head of the biceps comes up and it attaches at the top. You have the long head coming up to the socket, and you have the short head going over here to that bone called the coracoid. And believe it or not, I've never seen an issue with the short head of the biceps. Never seen an issue with it. The long head is very common to have an issue with it. And you can see it's this little thin tendon, and this is a beautiful, probably 20-year-old shoulder here. And this biceps attaches to the superior labrum. And so what happens is people will get pain in their shoulder. If they have a superior labral tear, they can get pain into their shoulder. They feel it right in the front, and then it radiates down into their biceps. It's not over on the side, it's deep inside in the front. And this is what my shoulder biceps looks like. And you can see the difference, that it's, inflamed, there's some rattiness to it, and you can get some people with just chronic pain, chronic superior labral pain, and that's called a slap tear, superior labrum anterior posterior. If you tear this tissue because it's beat up, banged up, or you decide you're going to do a 100-pound PR clean and jerk, you can get this, where that long head pulls away, pulls down your arm, and that's the long head of your biceps right there, because it pulled away. That's called a Popeye deformity. And that can be fixed, and you can take the biceps and reattach it, pull it back here. And that's a little small invasive surgery to do that. So that's the worst case scenario of a slap tear or a superior labrum. First of all, it's very common for someone to have a slap tear, in life. Over 40 years old, a lot of people have slap tears. And there are these tears here with the biceps pulls away, and you get sort of a traction. I describe it like a pulling on a hangnail kind of pain, where, say, you do this, that maneuver externally rotates the biceps and it can peel back. It's called the peel back phenomenon. The other one is if you jump from a bar and you hang down on a bar, you do butterfly pull-ups, and you're constantly, you're holding your body weight and your biceps is pulling up, then that can happen too. Imagine if you had traction on your biceps pulling that way. Other mechanism is you do a heavy deadlift and you're pulling, your biceps gets pulled down away from your shoulder, another possibility. And completely separate from that is someone's walking their dog and their 100-pound big ass dog pulls their arm and it pulls the biceps. So that's a completely non-CrossFit world thing. So those are mechanisms. The other one is pitching. Pitchers are notorious for having slap tears, and what happens is they're externally rotating, they're pulling that biceps back away from the socket. Most people with slap tears is a rehab, keep going, don't do anything, just rehab. And then if it gets to the point where they're having trouble sleeping because their arm is like this and they have this pain in the front of their shoulder, it's getting pinched in the front typically. You can, do a PRP, you could do a cortisone. And then again, these are people, say 6 months, 7 months, things aren't improving. You can do that biceps tenodesis, where you actually cut the biceps up here, you cut it, and then you do that reattachment into the humerus. So you don't have to have a Popeye deformity to have this biceps tenodesis for a slap tear.
Couple things. First,
Yeah, this is where you have a tear of the biceps right there. Like
yeah,
you can see how ratty it looks there.
yeah.
That's when you can do a biceps tenodesis. Here's another. Hopefully nobody throws up. But yeah, you can see that you have this inflamed tendon, and sometimes you don't have to have a slap tear. You can just have biceps pain, and this is a beat up biceps. And if somebody has that beat up biceps, then you can do this thing called a biceps tenodesis, where you reattach the tendon there.
If they do have a full tear, Sean, and need to have a reattachment, I'd always been under the impression that you got more retraction and it became more difficult the farther out from the injury you got.
Yeah.
One, is that true? And two, what's kind of the sweet spot where you want to get them in before there's too much contracture?
Yeah, I would say within 3 months is ideal.
Long. Okay.
2 months to 3 months, it's starting to scar down. But yeah, ideally, I've had some of the guys, uh, some of the games athletes, and they're all freaked out about it, and they come and they'll see me within a week, and we'll schedule them within another week, and I'll get in there within 3 weeks. And it's so the issue is that this the tissue retracts, it pulls down. It does pull down, and it can come way down here, and you have to get it and pull it back up here. So down here, there's a lot of other muscles. There's the short head of the biceps, there's the coracobrachialis, the brachialis, all these muscles down here, and then don't forget the musculocutaneous nerve right over here. So you get in there, and there's a wad of scar tissue, and you have to dissect the biceps off the musculocutaneous nerve or in that environment. And that's why we like to get in there before doing that.
Yeah.
Scar tissue, surgeons don't like scar tissue because it's, we like fresh injuries where you can just, see it, pull it, move it. You don't have to dissect and,
You do get to use the word ratty though, which is probably the coolest descriptor.
It's ratty. The tissue is ratty.
Got a ratty tissue.
Gnarly. That was a gnarly biceps there. That's a gnarly biceps right there. Here's a little interesting tidbit. So if you have a tenodesis here, say it rips here, or say you have a tendon tear here. You can have a biceps tendon tear anywhere here, or you have biceps tendonitis. This is the classic area for biceps tendonitis. I like to do my tenodesis down here, where this tissue, which is inflamed and ugly, just gets taken away, and you just reattach it here. And the studies have shown that people do very, very well. There's really not a lot of disability from doing a tenodesis. It sort of relieves pain. But there are some people that like to reattach way up here. And the problem is, as you can see, that this is where the groove is. That's where that groove was. And if you have this inflamed, ugly tissue here and you reattach it, I think you're still going to have problems. So I do what's called a subpec, which is below the pec, which is right down here as opposed to up here. So little tidbit.
How easy clinically is it to differentiate between a slap tear and biceps tendonitis as far as symptoms and exam?
Yeah, no, that's a good question. Sometimes you can't. Sometimes I'll be convinced they have a slap tear, and I'll get an MR arthrogram, and their superior labrum's normal, and then I'll just it'll be the groove that is bothering them. But yeah, you do what's called the speed test, which is pushing up. O'Brien, pushing up here. There's a bunch of others. The other slap tests where you put somebody's arm here and you pinch their arm up against their shoulder, and you say, okay, does that hurt? And they say yes, and then you relax the biceps and you ask them, does that feel better? Those are the ones that I like to do. There's probably about 12 different slap tests that you can do, but those are sort of the ones that I've chosen.
And while we're here, Sean, can you, for everybody, just describe how an MR arthrogram is different than a standard MRI?
Yeah, sure. So here is, say that you have a ball on a socket. The arthrogram is where they take a little needle and they inject fluid into the shoulder. And the shoulder is a capsule, and it's like a big balloon. And if you inject fluid into this balloon, the fluid on an MRI, say there's a tear here, the fluid will track underneath that. Whereas if you just did a regular MRI and you had a tear of that tissue here, you might not see it. It might not pop up on the MRI. But if you have fluid that sort of gets it travels underneath the tear, it exposes that tear, as opposed to no fluid and it sits like that and you don't see it. It increases the sensitivity up. I think it's about up to I want to say 85 to 95%.
Okay.
Yeah. So younger people, there's some people who say, okay, let's just get an MRI, and sometimes it shows up on the MRI if it's a big enough tear. But there are people that come in, and I've seen it, where they've had normal, quote unquote, normal MRIs, and I go in there and there's a significant labral tear that just didn't show up on, and it's not the radiologist missing it. It's just you don't see it because it's caked right up against the bone. Yeah.
And then logistically, folks go into, is it just IR that usually does the injection? Then they go in and get the
Yeah.
MRI.
Yeah, it's usually the MRI facility does the arthrogram
Okay,
and the MRI at the same time. Yeah,
great.
it takes about, with the MRI, with the arthrogram, about 45 minutes or so. Yeah. Yeah. Um, yeah, I mean, I could go on forever, but
No, that was fantastic. I mean, this is so informative for us to have an understanding of some of the most common presentations and discomforts that we personally experience or that we may hear as coaches, right? And so to understand the differential of what people may be experiencing and what the appropriate evaluations are is extremely important. And I'm glad we started with shoulder because it's probably our number one culprit. But man, I'd love from time to time to bring you back for our traveling joint series and just have you work
I
through
love it.
knee and
Love it.
hip and ankle and I mean, it's so informative and so helpful, Sean,
Oh, good.
for you to
Glad I
share
could.
your expertise here with everybody. I really, really appreciate the time. Jen, any major questions, anything you wanted to ask or anything that came up?
No, nothing that looks like in the chat. No, I will say just from a coaching standpoint and, obviously we as coaches in the affiliate and affiliate ownership know our scope and when somebody complains that something hurts and not just tell them to go harder and faster but to recognize that to your point
Yeah.
if somebody's saying something there's probably a reason for it, but insight into the anatomy and the way that things should work and just being able to ask simple questions like, well, does it hurt when you do this or does it hurt when you do that, can just help them understand what direction they need to take next, or go
Hmm.
on the directory and find Dr. Rockett and ask him
Yep.
for his opinion, or something like that. So I think that it's multifactorial in terms of the value that we all get by understanding, not only, and athletes too, right? Like we all do CrossFit. So like having insight as to that ache or pain and being able to say, okay, what is this telling me today? And what should I be paying attention to? It's great.
Yeah, those are really, really important points. And so just to reiterate that, if you are dealing with, an ache or a pain and have been less than thrilled with the experience that you may have had with an orthopedist or another healthcare practitioner, this is the reason why the directory exists, that you can reach out to doctors like Dr. Rockett to get an informed consult and an appropriate game plan. So please take advantage of that. It's free to reach out and contact him and set up a consult if it's appropriate for you. And then, Sean, I want you to just let everybody know how they can find you on social media and on YouTube and your book. If you can just reiterate kind of all those handles again and where they live and
Yeah,
what.
sure, sure, sure. The book is at Rogue, selling it through Rogue, roguefitness.com, and it's called Where Does It Hurt? It's an ebook. It's a virtual book where you can actually hear people talk about what they felt when they had a slap tear, what they felt when they had a rotator cuff tear, what did it feel like 5 months after a rotator cuff repair. So it's got these videos of people talking about that, links to articles, and then Instagram is 321GoMD. And then YouTube is Sean Rockett MD on YouTube, and I've got a bunch of videos there with giving you some exercises and things like that.
Yeah,
That's
I think you do a great job, I think, putting out really accessible and actionable takeaways for anybody, right? If athletes and coaches and stuff, just to be able to get insight and information about how we move, right? And this was great. I think a lot of times we talk about the metabolic state that we're all in, but
Hmm.
like understanding pain and injury and things that happen in real time, and the affiliate is really, really important. So I can't thank you enough for sharing your time with us.
Happy to help. Oh, and then professionally, yeah, Orthopedics New England is my group in Boston. We're out of Boston here.
awesome, Sean. Well, thank you again for the time,
Thank
sir.
you.
We really appreciate it. We will probably drag you back on Kicking and Screaming at some point to talk about another joint to educate us all. This has been really, really great, very informative and user friendly. So thanks again.
Thank you. Thank you. Happy to be here.
All right, hang out for a second, guys. I'm gonna stop the recording.